As I said, I have a lot of images and GIFs and graphs and special data here that I do not own, and so it cannot be reused or copied without authorization from the owners. Is this better?
Yeah.
Okay, great. So also what I'm going to discuss is simply my personal opinion. I'm only responsible for the content. I will be discussing some off-label uses. And so any mistakes or anything like that are purely my problem. So tonight, real quickly, we're going to talk about what mood disorders are like in a post-COVID transitioning world. And that's going to include looking at mechanisms of stress, vulnerability, depression, genes, heritability, relatedness, information, meaning, and a little bit about artificial a little bit about this may work, I guess, a little bit about artificial intelligence, and then finally talking about some good news. Last month, it was announced by Biden and numerous luminaries that COVID was over, that the PHE has ended. The public health emergency has finished in the United States. However, 1 in 13 adults currently are suffering from long COVID. That's about 7.5%, which last year cost an inordinate amount of money to the economy, $363 billion estimate. Long COVID is defined as symptoms which last 3 or more months. I have a number of people suffering from long COVID in my practice, and general fatigue is the most common symptom, as you can see here. And it goes down from there with a wide variety. I believe, and this slide does not really show this, that the kinds of symptoms that people experience with long COVID are directly related to which of the different COVID variants they got, because people that got the earlier have a very different long COVID. And of course, they had very different clinical presentations at the time. It's very interesting because older adults are less likely to have long COVID than younger adults. That was a surprise to me. Women are more likely than men. There's a number, I won't go over this for this audience, of different ethno-racial differences. But why it is that older adults are less likely to suffer from long COVID, again, is one of these mysteries that goes along with how we don't understand COVID, in my view, yet at all. Taking a look, though, at other things that are really creating a lot of anxiety and concern, we're still bombarded and in the back of our minds preoccupied with the daily continuous violence from mass shootings and the threat of World War III in Ukraine. This has led to what has been termed by the World Health Organization an infodemic, an overabundance of information, some accurate, some inaccurate, that occurs during a pandemic and leads to a lot of bad effects worldwide. Beyond these kind of bad effects from that, there has in the last couple of years developed chat GPT and other kinds of programs which cause or develop fake reporting and fake news. And a paper just published, you can see in May, the end of May, found that a truly phenomenal amount of neuroscience publications are faked. This was reviewing 5,000 medical and scientific reports in 2020 and finding that up to 30% of them were falsified either or plagiarized. And so this is another side of this coin that we're dealing with now. You probably heard Elon Musk come out last month stating that AI, artificial intelligence, is actually more dangerous than just about anything else and has the potential to destroy all of our civilization. They actually coined a term for that called technological obsolescence of Homo sapiens. And so that's another one of the things that is causing a tremendous amount of anxiety and depression. In fact, a large number of the US population seem to be emotionally overwhelmed, as I showed you in some slides last year. This part of on the left, which was published again last month, reported that teens' mental health in the United States has significantly declined over the past 10 years. With, you can see as you go along the column, increasing sadness reported, seriously considering suicide. And if you look in the lower left-hand corner, the suicide death rates, which starts in 2006 and goes up. In 2006, it was 33,000. The year where we have the most recent data in the United States, so 2021, is up to over 48,000. And similarly, data that was just reported here on the right by overdose death, which could be unintentional, but death by opioids and stimulants has been increasing very substantially. All of this, again, is reflective of the kind of state of our nation and the world. But now this group is primarily concerned with mood disorders, with depression. Depression, as we know, is the #1 cause of disability worldwide. 66% of people that develop depression are non-responders worldwide, and it takes about 11 years on average for someone to find effective treatment. Each year, there are 1 million suicides worldwide. These are new statistics, but they are very upsetting statistics, obviously. 60% of Americans suffering from mood disorders never receive treatment. And I'm here to say, along with DBSA, that we need to do better. We really need to do better. And it's through lectures like this and through public awareness and certainly public health efforts that we are going to be able to do better. Part of that harkens back to some of the earlier slides and taking a look at the media, taking a look at what meaning is when we see it in print or on TV, because what's deemed true, as you can see here, really may vary depending upon your point of view and not reflect the truth. For example, during COVID, everyone was extremely upset with all of the deaths that we were having in the United States. But if you take a step back from a different point of view and contrast COVID-19 with the Spanish flu from February 1918 to 1920, the Spanish flu infected a third of the world's population and killed between 50 to 100 million people. That was 3 to 6% of the world's population, where these statistics I gathered last night, the world death rate, the world number of deaths as of last night from COVID-19 was only under 7 million deaths. That's less than 1/100th of a percent. Contrast that with 3 to 6% of the entire globe. And similarly in the United States, back in the Spanish flu era, was about 0.5% of the population. And with COVID-19, it was about 1/3 of 1%. So we can clearly see that this point of view perspective is very important for taking a look at what's going on for data and for depression. When we take a look at depression, mood disorders, there's something called a stress vulnerability model, where adverse experiences lead to negative attitudes, and these get reactivated and activated by stressful events causing depression. This is called a stress vulnerability model. And this is the basis for Aaron Beck's cognitive theory of depression, in which dysfunctional attitudes or beliefs impede information processing to produce a negative cognitive bias, which leads to the symptoms of depression. Now, in the brain, this has been shown to correlate with the part of our ancient animal part of the brain, the reactive part, the limbic part of the brain, which has to do with impulse and emotional perception, and has connections with the higher order part of the brain, our prefrontal cortex, where we have judgment and planning and decisions. And what's been found is that cognitive behavioral therapy, as well as standard antidepressants, both lead to a decrease in this limbic overactivation. In fact, in this study, which was just published last month, they showed that this amygdala, which is the fight or flight overactivity, predicted improvement in both anxiety and depression symptoms. Now, part of this has a genetic component. And in fact, most all of the things that we typically consider to be neuropsychiatric disorders, autism, schizophrenia, ADHD, and bipolar illness, and major depression, all have some significant heritable component, although you can see from this slide that the rates, and these are not of just one or two studies, but in many cases, hundreds of studies that have been done trying to tease out what the heritability rates are really quite variable. Part of this depends upon, and this is taking a look instead of at the genetic part, the genes, what we call the phenome, that is how it's manifested phenotypically, the expression. And this is a different way of approaching the problems of major depression and finding out where it's from. And this takes a look. This was a study that was published in December in Biological Psychiatry, taking a look at the association of major depression with a whole lot of other physical illnesses to see whether it could be teased out exactly, or to a better, more precise thing, where major depression is coming down. You can see that the highest correlation genetically for what's called a polygenic risk score was actually among anxiety disorders, but there were a whole lot of things that were pretty high. The COPD, GERD, esophagitis, PTSD, of course, we know that, a whole lot of different things. This was a very large study from Europe of almost 47,000 very interesting unrelated subjects, so that these kind of scores were not one that was depending upon another family member. So this is very important. And it goes to show that there are many different biological mechanisms which link up with the environment to brain development and functioning, starting in the prenatal and perinatal, and then moving into the postnatal time in early development and later growth, where you have interactions with the environment. And this center part of the slide talks about the environmental risk related to functional brain connectivity. And this is taken from several different studies that I put together for the slide to just specifically highlight this kind of interaction for you. Now, moving on to taking a look at what many people really like, what I really enjoy, which is psychopharmacology, a very bright and shiny subject. Many factors contribute to psychotropic response. Some of them you can see here: comorbidity, adversity, trauma, drug level, cumulative drug exposure, hepatic metabolism, et cetera, et cetera. There are a whole lot of things. But if we break it down into just a few very simple common factors that you're aware of, it may be useful. The first is what we call the pharmacologic domains. These are the main neurotransmitters that you're all familiar with: serotonin, acetylcholine, dopamine, GABA, glutamate. Those are pharmacologic domains. Then we take that and we take a look at how they are being used and impacting the nerve cells themselves. And there are a whole lot of different mechanisms of action that they work as receptor agonists, as antagonists, blockers, as inhibitor of uptake of the chemical. We won't go through all of these, but obviously all of the chemicals are studied independently and interactively for each of these mechanisms. And it's very important to take those into account for a specific medication and for an individual who is in treatment, because things may differ significantly on each of these for a particular individual. Now, the next slide I'm going to show you, I found just fascinating. It is from earlier this year. It's from something called the Brain Initiative. And this is actually recorded from inside live brain, human brain, from an age. I can't really hear it, you see, because they're narrating it. He's talking about so this was one major award for neuroscience visualization showing real live action potentials. I mean, it looks almost, like a movie, but it's real. Now, we get to the next slide. I think it's, let me see if I stop it. Okay. Now, this is a slide saying we can work up to antidepressants with all this talk about neurotransmitters, but for now, I want to start you on eating a whole jar of cocktail olives over the kitchen sink. And so I put that in to remind us that there are nutraceuticals. And this is a study that was hasn't been published. It was presented at the first international meeting that I've been to since 2019. It was the International College of Neuropsychopharmacology. And this was a poster. And I actually see the poster. I took a shot of it. I found it very interesting because it's from China, but they did some good research. What they did is they took a look at a whole lot of different nutraceuticals, many of which you've heard of: SAMe, ADT, different B vitamins, DHA, the fish oils, just a whole laundry list. And what they found, and they compared them with effects in depression, treatment of major depression, with standard antidepressants. A very well done study, which is why it was accepted for presentation to CNP. And these adjunctive nutraceuticals showed a better efficacy when added to standard antidepressants than the antidepressants alone for remission of the symptoms of major depression and response over time. This is a greater than 50% improvement in depression rating scores. These ones in particular were much better. The SAMe, curcumin, and saffron together, EPA, DHA, that's the fish oil stuff, SAMe and curcumin. And for most of these nutraceuticals studied, the tolerability was no different than taking a sugar pill. So that's a really important study, and I was pleased to see that. I'm sure it'll come out in press sometime, but you're getting to see it before it's been published. When we talk about boosting antidepressants, there are a whole lot of different mechanisms that we can see have been used. The first ones were described for lithium and for buspirone, and then came in the what are known as the atypical antipsychotics. Well, the first one was actually risperidone, which I published, but then all these other ones, the olanzapine, aripiprazole, Abilify, ziprasidone, Seroquel, all these. And there's good data for the ones on the top half, that is efficacy data of this slide, but not too much efficacy data, even though many of them are frequently used on the bottom half. When I say frequently used or efficacy data, you can see in the bottom half the ketamine, S-ketamine, and nitrous oxide, which I predict will be approved sometime in the next 2 years, in which some of you may remember I talked about in here about 2 years ago. The ketamine, of course, has been approved, and it's really the question of efficacy data that keeps it in the bottom half here. Some of the antidepressants now that we're going to talk about are very exciting because they have new mechanisms. And these novel mechanisms that are being invented then lead to new treatments. The first of these that's worth mentioning is dextromethorphan bupropion. Both of these have been around for quite a while. Wellbutrin, of course, any of you that take Robitussin DM or any of the DM formulations, that's what dextromethorphan is. Well, what dextromethorphan does is it increases by itself glutamate signaling. Glutamate is the brain's most abundant excitatory neurotransmitter. But it also downstream increases the calming inhibitory neurotransmitter GABA, which promotes sleep, relaxation, anxiety regulation. So you say, well, so why hasn't dextromethorphan been used as an antidepressant previously? Well, because it's very rapidly and extensively metabolized through one of the liver enzymes, a cytochrome P450, 2D6 enzyme. So bupropion here is not being used so much as an antidepressant, but because of its profound ability to block this 2D6 metabolism, thereby letting a huge increase of dextromethorphan get into the brain with a very rapid, this paper was published last month, with a very rapid and beneficial improvement in depression scores. This is a new compound that has been, it doesn't even have a brand name yet. It's being called AXS05. It'll be coming to a drugstore near you soon. A new one, which I spoke of last year and the year before, and I'm happy to say is just filed in February for FDA new drug application, is still doesn't have a brand name, but it will when it gets, they are not going to release that until it gets the approval, the brand name. But zuranolone is a GABA A receptive modulator. It modulates GABA, this major inhibitory neurotransmitter. This study, which is also quite recent, I think published in the last 2 months, was another one that showed that a single 50 milligram pill of the zuranolone once a day in the evening, has to be taken with a fatty meal, start showing dramatic antidepressant effects within 3 days. Now, this is much faster than any of the SSRIs and almost any of the other pill type antidepressants, and you get significant full relief by 2 weeks, 15 days on this. It also benefits sleep, and there's no evidence of building any kind of tolerance or dependent to it. I had, as I mentioned, I was very excited about this last year and described it, but it's come obviously a lot further along. It has a sister compound, brexanolone, that has FDA approval for postpartum depression, but that one requires an IV infusion. However, a single IV infusion, which is given over 60 hours postpartum, where, as you know, women have these severe postpartum depressions. The single infusion of this Zulresso treats postpartum depression for 30 days. And by that time, they're generally completely out of the depression. So that is quite remarkable. And that's just a sister compound, similar mechanism. When we think about biological mechanisms of bipolar disorder and try and relate those to treatment for bipolar disorder, we say, well, maybe I need to change my life. Or maybe you could just tweak the medication. I have a whole, I'm not going to go through all of the calcium channel stuff, and there's a whole lot of different things in here with the brain, and we can say that to another time, but there is a lot of good research that has been done to try and ferret this stuff out. Um, One of the atypical antipsychotics I mentioned before, lumateperone, simultaneously modulates a bunch of different neurotransmitters. And this, again, was a study that was presented as a poster 3 weeks ago at CINP, finding that it has a very beneficial effect for bipolar 2 depression. Most of these things have not been well studied for bipolar 2. So this is the start of a new trend that we're getting better treatments. However, moving beyond medication treatment to some of the biologics, the brain stimulation treatments for depression, we've talked in here many times about them. Of course, ECT, electroconvulsive therapy, is by far and away the most potent antidepressant known. It is effective in over 80% of individuals. There are some problems with it, and one of the major problems is that the general public is afraid of it because of One Flew Over the Cuckoo's Nest. And so people don't get it, but it also, interestingly enough, works for Parkinson's disease, works for acute schizophrenia, works for a whole lot of things, probably because it causes this blast release of many, many neurotransmitters in the brain. Beyond ECT, of course, now in the last 10 years, it's hard to travel throughout the United States without finding a TMS center. Transcranial magnetic stimulation is a very remunerative procedure for people setting up these treatments, and they can charge a lot of money, and insurance doesn't pay. They do have some real benefit for people that do not respond to regular medication. There's a newer form of it called the TMS Saint-based protocol, which I mentioned in here actually 2 years ago. And I took this right out of the internet to give you an idea of what we're talking about. This is a picture of the machine. A treatment costs $6,000 and it's self-pay only. So now another side of the stimulation is something we've talked about here, which is going deeper into the brain. TMS is just on the outside. This is a recent, they have a recent paper, which is called Deep TMS, where they actually are getting much deeper into the brain, and it looks like they're having a bigger effect. And this, I think, is probably going to be the wave of the future. Beyond that, how about psychedelics? Since this is all the rage these days. Yes. And of course, the one that has been grabbing everyone's attention is psilocybin. Why is that? Well, because it has a very high initial success rate. And like the other psychedelics, LSD, mescaline, it works on the serotonin 2A receptor. And this study, which was presented by Mayo Clinic 3 weeks ago at this conference I went to, was taking a look at finding the optimal doses of psilocybin in mood disorders and reviewing that. And they came up with 10 to 25 milligrams a day among the studies. And so there's a lot of work being done on this. And people are starting to get treated with psilocybin off-label, that is, not in doctors' offices, because it's not really legal here. In England, it is. And there was a huge um, presentation at Biological Psychiatry this year and at CINP on its use by a group from England, since they've had it for a long time. The important thing about all of this that gets lost in the media, and that's why I put the point of view slide, is in here. Well, it's in here if we can advance a slide. Most all of the studies on psilocybin has strictly precluded it being given to bipolars. Anyone with mood swings cannot be eligible for the studies. And there have been cases reported, like this one in December in the American Journal of Psychiatry, of a single dose of psilocybin provoking severe, prolonged mania, psychosis, and then followed by severe depression. Okay. Interestingly enough, not only that, but a paper published, I think 2 months ago, coming out of New York, they were in a psilocybin research protocol, and they gave a young depressed guy psilocybin, and he had a wonderful antidepressant response, but he had no kind of hallucinations, no psychedelic experience. And they went back and found out that unlike the protocol, which enforced being off of all medications, all psychotropic medications, a month before getting psilocybin, this young guy had continued to take his 200 milligram of trazodone every night, including the night before he got the psilocybin. Now, trazodone blocks 5-HT2A, the serotonin 2A receptor. So it raises the question, well, are the psychedelic effects of psilocybin even related to serotonin? So this is really interesting stuff. I mean, the guy had a very positive, it's not saying that he didn't have a good antidepressant response. He did, but we still don't know what that's about. Now, the other psychotropics that people are using willy-nilly, of course, state after state after state, it's a marching of approvals in the state. This was a study that was published last month in JAMA Psychiatry, which took a look at over 6.6 million individuals who developed cannabis use disorder, and found a huge increased risk for both unipolar depression and bipolar disorder. So there was a previous study that I mentioned in here a year or two ago, which found that 1 in 3 individuals who experience a psychosis when they're using a substance, it didn't have to be marijuana, but most commonly was marijuana, actually, who did not have a previous psychiatric diagnosis, then became bipolar or schizophrenic, triggered by the marijuana. And bipolar disorder had the highest rate of conversion from this psychosis by cannabis. Very important. So how do we sort of tease this stuff out? Well, one of the ways that science is taking a look is the use of biomarkers, specific things in the brain that can be measured to detect disease, to stage it, to respond to treatment, monitor progression. These are things like functional brain activity, which is now moved into what we call network neuroscience. This takes a look at brain function as a web of interacting component networks, having to do with resting state of brain function. Some of them you've heard of: the executive control network, the salience network that determines sort of the importance and salience to things. There are various auditory networks. There's and there's, of course, the default mode network, which is what we all enter if we're just not thinking about anything and having random thoughts. Of great interest was 2 months ago, where a completely new network was discovered, published in Nature. And there's where it is in the brain. It's a network that they termed the somatocognitive action network, or SCAN. And it is a network that subserves the integration of mind and body, of goals, physiology, and body movement. So this is brand new. Actually, it was May 11th it was published. So I'm sure we will be hearing more about this, and we may be hearing about how this interacts with not only prescription medications, psychotropics, major depression, and addiction. When we go back and think about treatment ultimately of depression, there are just a couple of rules that I recommend we hew to. The first is, if the individual has mood swings, if they're bipolar, then a mood stabilizer is absolutely essential. And we have to beware that antidepressants, any antidepressants, have a tendency to, over time, worsen mood, causing cycling, if the person has any proclivity at all to bipolarity. Having said that, all of us here know that the best and tried and true thing for mood stabilization is actually lithium. And that's not what this slide is about. This is about something that I've talked in here about before, but which there was another paper presented 3 weeks ago, which showed that microdoses of lithium have significant benefits when contrasted with placebo at preventing cognitive decline. Benefits of these tiny doses of lithium also were found when added to antidepressants to diminish depression and manias. And low dose lithium, unlike the higher therapeutic doses that most manic depressives take, are uniformly safe. They don't do any kidney damage. And I've reported in here before about the study out of Denmark that had 600,000 individuals and was found to have real benefits at preventing not only Alzheimer's disease, but Parkinson's disease and some other neurodegenerative. In fact, this low dose lithium, 46% of these people with these microdoses rated moderate improvement, and 25% large to very large improvements. There's also another very recent study published May 21st that showed that chronic lifetime lithium use is associated with expansion of the length of that DNA sequence called a telomere, which has to do with aging. So it's not only preventing cognitive decline, but it may actually be retarding aging. Now, so why isn't this stuff used more frequently? Well, for one thing, bipolar illness is often very difficult to diagnose. It's often misdiagnosed as either depression, ADD, or anxiety. 37% of bipolars are initially misdiagnosed as unipolar depression. That's almost 40%, okay? And within 15 years of hospitalization for major depression, nearly 50% of all patients hospitalized for major depression suffer mania. I mean, that's an amazing statistic. It's an amazing statistic. You also have to really take a look at distinguishing between anxiety and depressive disorders, because anxiety disorders are more common than mood disorders in the general population. 25% of US adults will suffer from anxiety disorders. And of course, there are a number of different important ones. I won't go through them, but there's also a very significant overlap of anxiety disorders with depression. And that has to be taken into account. Now, one of the confounding factors that also leads to misdiagnosis is a misunderstanding the symptoms of hypomania are just mild highs or mixed states, because most hypomanias only last about 2 days. And even the DSM requires 5 days or 4 days to get a diagnosis. So if you have 2 days of hypomania, you're not going to garner a diagnosis of being bipolar 2, 3, 4, or 5. And by the way, some classifications do go further down. They do bipolar NOS, that's not otherwise specified as cyclothymia, that is changes every couple of days. Bipolar 3 is said to be antidepressant related hypomania. Hyperthymic, that people who never really get depressed at all. I've seen maybe half a dozen in my years in practice because they never get depressed. So they come to me because they have insomnia. And then recurrent unipolar depression. The other problem that hypomanias don't get diagnosed is because they generally fade away by the time an individual gets into their 40s or 50s. Another major diagnostic category that I almost hesitated to bring up, but because it has such significant mood fluctuations, is borderline personality disorder. The individuals with this have rapidly, abruptly shifting short mood depressive episodes or elevated episodes, and can become psychotic, like people with mood disorders, but it's usually very transient. And although they also become suicidal, they're less likely to really kill themselves, and the suicidality doesn't tend to occur in the context of being severely depressed for a long period of time, because they don't remain severely depressed for a long period of time. But in the context of psychological stress. Unfortunately, of course, there are a certain percentage of people that can suffer from both things, that can have biological mood disorders or bipolar disorder and a personality disorder on top of it. And that makes diagnosis as well as treatment even more difficult. So where do we go with that? Well, one of the things that was introduced at this international meeting was a development of what's called a neuroscience-based nomenclature, which is aimed at updating the classification of psychiatric medication. It's being updated yearly. Clinicians, physicians have actually an app that they can get, which is supported by American College of Neuropsychopharmacology and launched by the European College of Neuropsychopharmacology and this international college that I'm a member of. And it provides a teaching tool for clinicians, and there are actual exams, little quizzes that doctors can take. You diagnose a patient with bipolar. How can the NBT app help? How can you do this? And with this app, You can type in the name of whatever medication you're thinking about. You can find the pharmacology, the mode of action. So this will really serve to further educate, because a lot of the people that are prescribing these medications, frankly, may not be on top of this literature. So I think that is going to be a real important thing. Now, unfortunately, with the end of COVID, quote unquote, telehealth has stopped, and many of you who are seeing individuals may not have returned to see them in person. It's only a small percentage of people that I'm seeing in person. People they enjoy telehealth, but there is a ongoing thing with the AMA now until the end of this month about, well, what do you do since the PHE has been declared over? How do you protect it? What do we do? Another thing that's being launched is, and this was launched just 2 weeks ago, the FDA launched for patients something called a PMI. It's the patient medication information. It's different than your package insert, and it will be uniformly available for every single medication that you get. And it simplifies things, gives you information you need on every drug in the United States. This is brand new. Another new thing that is very exciting was just published in Nature Neuroscience. And this is actually a wearable device that reads single neuron and local field potential in the brain in freely moving individuals. So this is going to give us data that we can use for treatment and will, I think, further let us fine tune a lot of what we're doing. However, one of my predictions with all of the AI and all of these kind of technological advances is that a majority, you heard it here first, a majority of mental health evaluations and therapies are going to be AI generated within 5 years. In other words, you're having depression, you're going to be talking to a chat bot, and you're going to be getting therapy for a chat bot initially, unless you don't respond, and getting medication prescribed by Chat GPT. That's my prediction. And there are at least 30 companies that have already developed these kind of chatbot enterprises. So that is working. Now, something positive that was launched here at GW just 3 weeks ago was, anyone know this guy? Listen. This is Jose Andre, and he, in conjunction with George Washington University, has launched the Global Food Institute to tackle not just climate change, but political change through the vehicle of hunger, figuring out through food system solutions. So this is really approaching some of these problems from a different perspective that I think may be really important to do. So the final take homes tonight, some of you remember something like this slide before, where I talk about health maintenance for yourself, for keeping yourself, getting yourself healthy and keeping yourself healthy. And that involves getting a standard sleep-wake cycle, which is enhanced by bright light therapy, even a small amount in the morning, blue light blocking glasses in the evening, and melatonin sometimes in the evening to help synchronize, avoiding things that would give you blue light or activate the brain, like the internet or video games after 9 p.m., uncomfortable sleeping environments, afternoon caffeine, and of course, cigarettes, alcohol, recreational drugs. And Also getting out and walking and doing regular exercise. We know that the exercise improves your metabolic activity. We know it's a very potent antidepressant. It reduces anxiety, and it will be the best thing. They've now shown that as little as 12 minutes of walking a day. This was an older thing, 22 minutes. Now it's down to 12 minutes of walking a day. It looks like it will stave off Alzheimer's disease. I mean, that's remarkable. That's remarkable. So that's it for this evening. Thank you very much for your attention. Open for any brief questions that people might feel. Yes.
Yeah, I have a antidepressant that was brought up.
Mm-hmm.
And this in February, March, I started getting manic,
Mm-hmm.
so I cut off the Robitussin.
Mm-hmm.
I stopped using my lights.
Mm-hmm.
I stopped taking Trazodone.
Mm-hmm.
What it was is I had cataract surgery.
Interesting. That changed the light level.
It
It makes sense. It makes total sense because, of course, you got a big sudden blast of increased illumination. Yes, absolutely. Yes, yes. That you should report that. You get someone to write it up. It's definitely over here. Uh-huh. No. Well, no, that's actually not true. Yes, it can cause mania. It can cause hypomania. That is true. But in our original studies at NIH that developed light therapy, what we found was that above 84% of people that are seasonal, that have seasonal mood swings and respond to light, actually are bipolar of one form or another. So if you're a bipolar 1 and very exquisitely vulnerable to perturbations in your environment, you may need just a small amount of light, a minute or two in the morning, to synchronize your sleep-wake cycle, your biological clock, once you're in springtime or summer, and you may need more than that in the winter, but it's a mistake to write it off because you're bipolar. Sure. One more
Could you
question.
please relay the questions?
What about this new tardive dyskinesia medicines? Are they working very well?
Okay, so the new tardive dyskinesia medicines, I had presented a slide on those not last year, the year before. Yes, they do work. I felt it was sort of ironic because these companies that are launching them are the same companies that are producing the dopamine blocking agents that cause tardive dyskinesia. And so they've actually created the problem, and then they're fixing it with these medications. And they do work, but they are generally out of pocket and between $60,000 and $70,000 a year. And so, you know, what can I say?
Is there a question from the Zoom audience?
Where would I see the question from the Zoom audience?
I thought I heard someone.
Oh, let me look at chat. Let me
People on Zoom, is there a question? Is someone here?
see if I can.
Chat?
Let me see if I can go on to chat.
Can you check chat?
Yes, here I'm checking chat here. Yes, here we go. Thanks. It says, thank you so much. Is there information on misdiagnosis of bipolar in women versus men? That's an excellent question. I suspect that it is less commonly misdiagnosed in men than women for a lot of reasons, because women, of course, have their menstrual cycling, so there's an interactive effect between the menstrual cycle and bipolar cycles, and also the different phases of the menstrual cycle, with, of course, as women are approaching menstruation, they have a huge drop in estrogen, which lets them have their menses, but that also in the brain causes a huge drop in serotonin, so they get depressed. So I don't know the exact answer to which studies have specifically asked that question, but I'm quite sure that it is in the direction I mentioned. See, could you, let me see if there's anything else here. Okay, I think that's it. So thank you very much.
Thank you. Thank you, Dr. Jacobsen. Thank you, everyone here. If I may, let me.
Thank you all for coming.